Mr. Houghton. Thank you for helping us with the assignment about the role of nurse practitioners and ethics at end of life. We understand that due to HIPAA regulations, no patient identifiable data can be shared. The process for a patient to be designated as DNR, no escalation of care, withholding therapies, or withdrawing of care, and what is their role as a nurse practitioner in that area.
Often the nurse practitioner role is a primary one because we have a lot more contact often with the patient families than some of the attending physicians do, because we're there, in the unit, and the families know us for, a period of time. So often they will introduce the subject, or I will introduce the subject, with them if I feel it's appropriate, or if they have, interests or concerns in that. The technical process of becoming, making a patient comfort care, or actually we're trying not to use the term DNR anymore, we're trying to use AND, which is allow natural death, which I think is a much better term actually, because DNR implies that we're withholding something and taking something away that the patient needs, whereas the allow natural death process, is a much better term that says we're not doing anything wrong, we're just letting nature happen as it should. The process is a fairly simple one. Really, it's meeting with either, most of the time the patient is not able to be involved, at least in the ICU. They're not able to be involved in that kind of a decision-making process. So that would fall to myself as the nurse practitioner, preferably with a multidisciplinary team, with the patient's attending physician and a social worker and perhaps one of the bedside nurses. We then meet and discuss different care options, and the family will often ask us for recommendations on what we might recommend. If it was our mother, often they'll ask us that kind of questions. And I think that's okay to offer. And then we'll basically negotiate kind of what would be the best for that patient. There can be an array of options, such as we will do this and we'll continue the mechanical ventilator, but we won't initiate dialysis if the kidneys fail, or we won't start hemodynamic support if the blood pressure starts to fall. So it is a negotiated process, and then specific orders need to be written after that meeting. There's no form for the families to sign, at least not in this hospital. Simply documentation of the family meeting, and then the attending physician will write the orders in the chart to clarify the conversation. We're moving towards, I know I'm getting long now, we're moving towards a new form, which is called the POLST form, which I would recommend. I don't know if you've heard of that, POLST, Physician Orders for Life-Sustaining Treatment, which we're rolling out now at Jackson. It's not in widespread use yet, but it will be in the coming years. And that very clearly specifies what levels of care you negotiate with either the patient or family.
Okay. I can imagine that working in a high acute ICU here in Jackson, you encounter frequently complicated ethical issues that surround a patient. Do you remember any particular ethical challenge that you can share with us?
Yeah, absolutely. We had a recent case, and not in this particular ICU, but in another ICU, where it was a family from out of town. The patient was a child, a grown child, an adult child, but the family was on vacation in the islands, and an event occurred, and the child had a severe brain injury, anoxic brain injury, which is not likely going to reverse itself. We believed that the patient was indeed brain dead. However, the parents were healthcare providers, and they knew where we were going, and they refused to let us do the workup. They said, no, we won't allow you to do these brain flow tests. We don't want any of these things done to her. Just continue her support and have her transferred back to our hometown hospital. It was very awkward. It was very uncomfortable. The ethics committee was involved, and that was one of the most difficult cases that I remember, because it was really an issue of we believed the patient was dead, brain dead, and we weren't able to
And they were
clearly
care
establish it,
providers,
and they
yes.
were aware that the patient was clearly brain dead too, but just weren't ready to accept it. It was very awkward for everybody.
Who is the provider responsible to take care of the decision to start the no escalation of care, or how do you as a nurse practitioner have to confront this on a daily basis?
I kind of said before a little bit about how I often end up starting these conversations because, I'm acutely involved with the families on a regular basis, and so that, comes my way often. But the more formal process is for me or the family to involve the attending physician of record, because that's the way the hospital policy is, and that's the way the Florida law is, that the attending physician has to make that decision with their
with the
patient
family.
or family.
Okay. How are these decisions shared with the family members or proxy? For example, here in Miami, that we have so many different cultures. Like, you can see any difference between one culture and another?
Yeah, absolutely. There are huge differences between the different cultures. And I'm from New York, a very white American culture. I really didn't know anyone who spoke Spanish or any African Americans when I grew up, and the cultural differences are really, very, very different. How white Caucasians, will grieve, is usually much more quiet and low-key versus the way some of the Latin cultures or the Caribbean cultures especially, not just Latino, the Haitian and other island cultures, are often extremely expressive and with a lot of wailing and carrying on and what I would consider drama. The decisions are often made differently as well. In my culture, for example, things are pretty much, it would be, there was a proxy designated, and that would be the person that I would communicate with, and that would be pretty much it, fairly straightforward. But often in the African American, Caribbean, and Latino cultures, it's more of a group process where they bring everybody in, and you have a family meeting with 25 people, and kind of as a group, often with different sides, sometimes raising different points or feelings, they will come to more of a group decision on what was best for the person.
Wow. Any recommendation for the future nurse practitioner, both as a primary care and acute care providers, that will facilitate the end of life in the ICU?
Yeah, I think especially for primary care providers, you have the super important role of trying to talk to patients about this kind of stuff early before it becomes an issue, especially if you're dealing with patients who have, either an advanced age or some kind of chronic health problems, which, may get worse during the coming years. I think it's so important to talk about these kinds of things and document that kind of thing in their record somewhere, or encourage them to do so privately so that they have some kind of advanced directives, or at least a decision maker chosen ahead of time, somebody who knows how they would think. And I think that's super, super important for primary care, especially.
Okay. Thank you for your time.
You're very welcome.